Hello everyone, welcome to the channel. This is Clinical Reasoning series. Today I am going to discuss the case number 10. Please note that this discussion is only for academic purposes and cannot be directly related to the patient care. This is a summary of the case. A 75-year-old female presenting with worsening of abdominal pain. There is a past history of hypertension and ischemic heart disease. Coming to the abdominal pain, this is worse after eating and decreases after 1 to 2 hours. It does not radiate to the back and not associated with nausea or vomiting. There is a history of weight loss and anorexia present. It is also mentioned that the investigations include normal liver function test, amylase and blood counts. The question asked is, what is the likely diagnosis in this patient? Chronic gastritis, chronic cholecystitis, chronic pancreatitis and chronic mesenteric ischemia. When I posted this question in the Telegram group, most of you were able to rule out the options 2 and 3, namely the chronic cholecystitis and chronic pancreatitis. The confusion was between the other two options. So let me just try to approach this particular case and tell you the final diagnosis. In this particular case scenario, based on the history and investigation, we can rule out chronic cholecystitis as an option because you all know that chronic cholecystitis is something which is seen in a middle-aged females, what we commonly remember as 4 F's, which includes fatty, fertile and 40 females. That's what you remember as the 4 F's. And you know that most often associated with the gallstones. So this chronic cholecystitis classically presents like a colicky abdominal pain. Okay, presents like colicky abdominal pain, which was not mentioned in this question. And one more thing is that they have intolerance to fatty foods. It's a very important feature that once they start taking the fatty foods, they develop this abdominal pain. They also have this dyspepsia like symptoms. So that is called intolerance to fatty foods. This is a very prominent feature and should be present in the question to point you towards the diagnosis of chronic cholecystitis, which was not given in this particular case, right? So that is why I am saying that chronic cholecystitis is very unlikely in this particular scenario. Then why not it is chronic pancreatitis? Look at the characteristic feature of pain in chronic pancreatitis. In chronic pancreatitis, the pain should radiate to the back. Is it not? It's a very common finding that in pancreatitis, the pain should radiate to the back. In this particular question, it is very clearly mentioned that the pain does not radiate to the back. Right? And one more is, if you look at the investigation, it is already mentioned that the patient is having normal amylase level. You all know that amylase and lipase levels are going to be elevated in case of pancreatitis. So, because of this, I can rule out chronic pancreatitis in this particular patient. So, your doubt is between chronic gastritis and chronic mesenteric ischemia. Equal proportion answered chronic gastritis and equal proportion answered chronic mesenteric ischemia. Now, I will tell you the diagnosis and tell you how did I rule out the other option. The diagnosis here is chronic mesenteric ischemia. So, for those who have marked chronic gastritis, I will tell you how did I rule out that particular option. Chronic gastritis, even though the pain may be postprandial, the point to be remembered is that it is usually associated with upper GI symptoms, namely the nausea and vomiting. They are all very prominent features. Nausea and vomiting are all very prominent features of chronic gastritis, which are actually absent in this particular patient. You go back to the question, it is very clearly mentioned that the pain is not associated with nausea or vomiting. This is a very important clue to rule out sort of gastritis in this particular patient. But please remember, most of the times, because gastritis is relatively common than the other condition, many physicians think that this is gastritis and start treating them with the that proton pump inhibitors and all, okay, reflex decreasing medications and all. However, they will not find any response even after starting the proton pump inhibitors for 4 to 8 weeks. Only then they think about alternative diagnosis. But this MCQ question, you have to be to the point, and because it is not associated with nausea or vomiting, I can rule out chronic gastritis in this particular patient. Then you can ask me what pointed to the diagnosis of the other option, namely the chronic mesenteric ischemia. Look at this history. Can you see that there is a past history of hypertension and ischemic heart disease, and it is a 75-year-old female. So the common association would be atherosclerosis. Is it not? Common association would be atherosclerosis. In fact, atherosclerosis is the most important association with chronic mesenteric ischemia, which is a diagnosis in this particular case, right? So let us discuss some important points regarding chronic mesenteric ischemia. As the name suggests, chronic mesenteric ischemia is a condition of decreased blood supply to the bowel which deteriorates over the time. And what is the association I told you? Association is atherosclerosis. Now this atherosclerosis can involve most of the arteries, and in chronic mesenteric ischemia, the affected arteries would include the celiac trunk, superior mesenteric artery and inferior mesenteric artery. Okay, right. Now I would want you to remember one very important point here. This celiac trunk, superior mesenteric artery and inferior mesenteric artery, which are the arteries supplying the bowels, they have got a very rich collateral blood supply. So that is why a small occlusion of these arteries may not be associated with severe ischemia. It is required that at least two of these arteries needs to be significantly occluded before you can have the symptoms of chronic mesenteric ischemia. Are you able to follow this? So remember, rich collateral blood supply is actually a protective factor against the development of chronic mesenteric ischemia even if atherosclerosis is present. Okay, right. As you would expect, this is common in elderly, and females are the ones who are commonly going to be affected. The second point to be remembered is there are some risk factors for development of chronic mesenteric ischemia, which basically are the risk factors for development of atherosclerosis or progression of atherosclerosis. What are the risk factors? One is aging, second is hypertension, third is smoking, third is diabetes mellitus, fourth one is increased levels of cholesterol, as you would expect for any case of atherosclerotic acceleration. Okay, right. The classical clinical features of this disease could be remembered as postprandial, because postprandial is the time when the bowel actually requires increased blood supply to take care of the digestion and peristalsis. But because of this atherosclerotic induced occlusion of the arteries, postprandially the blood supply may not increase, so that is why this patient may have postprandial pain. What we also call it as a intestinal angina. Okay, right. That was what is given in the question. Second is because of this pain, the patient may refuse to take food and all, and this can be associated with weight loss. Okay, postprandial pain and weight loss are characteristic feature. Remember, always you have to have some history of comorbidities, which was actually given in this particular question. What is that? It was history of ischemic heart disease. Some patient may have history of stroke as well. These are all features that the patient had experienced atherosclerosis and experienced some complication of this accelerated atherosclerosis. So remember, there should be some comorbidities of accelerated atherosclerosis like ischemic heart disease or stroke. Then what is this condition? Cytophobia. Cytophobia refers to fear of eating, because once they start eating, they have this increase in the pain. So that is why they have this fear of eating. This is called as cytophobia. These are the four characteristic features which you should always look for whenever you are dealing with a case of chronic mesenteric ischemia. So how do you diagnose this particular condition? Or if I ask you what is the investigation of choice, your answer is going to be what I have given in the picture, which is nothing but CT angiogram. CT angiogram. This is supposed to be the investigation of choice in this particular condition. So what will be the treatment? You all might have studied about treatment of ischemic heart disease, which is actually atherosclerotic occlusion of the coronary arteries. Similarly, here it is atherosclerotic occlusion of the artery supplying the bowel. So what will be the treatment? Yes, the treatment is nothing but balloon angioplasty along with stenting, which is an endovascular procedure, and that is supposed to be the investigation of choice. Suppose they don't give this, they can just give you a simple option in the question as revascularization. That's all. Revascularization. It's an endoscopic procedure wherein you have this balloon angioplasty with stenting, which is also called as revascularization. So that is about the approach to this particular case and short description of chronic mesenteric ischemia, a very important condition which is often missed, thinking that it's a chronic gastritis. So thanks for watching this video. Hope you have liked this video. Please share it with your friends and don't forget to subscribe to this channel, and please press on the bell icon so that you get notified about new videos as and when they are posted. I will see you shortly in another clinical reasoning case. Thank you and have a good day.